Welcome to the premiere episode of our three-part series, Case Studies in Treating Ocular Surface Disease. We are joined by an expert panel of Drs. Ivan Mack, Damon Dierker, and Brandon Ayres as they discuss a myriad of interesting cases along the ocular surface spectrum. Dr. Ivan Mack kicks off the series with a unique cataract surgery case.
Hello, welcome to this ocular surface disease symposium. My name is Ivan Mack. I'm the founding partner of Metro and Eye Associates. I practice comprehensive and cataract and refractive surgery in Charlotte, North Carolina. And I wanted to go over a nice case that we typically see in everyday practice. And hopefully you can pick up a few pearls as we go through it. I'm joined by my esteemed colleagues, Dr. Brandon Ayres and Dr. Damon Dierker, who will be assisting me and giving commentary today. This is a unique case presentation. This is a 66-year-old lady who's referred for cataract evaluation, coming in complaining of course, blurry vision and cloudy vision in the right eye more than the left eye. She has a past history of dry eye, cataracts, and what's unique about her is she had a history of LASIK in one of her eyes, and she wasn't sure which eye had had LASIK surgery. She was using Refresh every day for her artificial tears. Past medical history, she had diabetes and hypercholesterolemia. Medications are as listed, nothing unusual. Best corrected visual acuity had decreased to 2400 in the right eye and 2050 plus 2 in the left eye with the refractions as shown. Again, hard to discern which eye had had the LASIK from the refractive data. Pupils, motility, visual field, IOP were all normal. And as you can see, we did obtain baseline tear osmolarity testing, and she has a significant elevated tear osmolarity in the right eye more than the left eye. So this is the slit lamp examination that we obtained. We noticed that she had moderate meibomian gland dysfunction, no really significant blepharitis. She of course had a diminished tear film and 2+ punctate keratitis staining inferiorly. Her cataract was shown worse on the right eye than the left eye with significant PSC changes. Posterior segment was pretty much unremarkable for a diabetic. Cup to disc ratio was normal, no diabetic retinopathy, bilateral posterior vitreous detachments. We obtained topography as shown, and also her higher order aberration analysis. She does have some cylinder in both eyes that's about 48 degrees at the steep axis. And you can see at her spherical aberration of -0.024, it's a little hard to ascertain. Maybe this is hyperopic LASIK, maybe not. Again, with myopic LASIK, we'll typically see higher positive spherical aberrations. Hyperopic LASIK, we'll see negative spherical aberration. So we assumed maybe hyperopic ablation. We weren't sure which eye. And again, from the topography, there she has astigmatism in both eyes. So this case brings up a number of points. First of all, she has, significant ocular surface disease. So I'd like to open it up to the panel in terms of, how would you like to tune this patient up for cataract surgery? What are the options that are available? How long do you treat her for? And then maybe we can have a discussion about maybe an appropriate intraocular lens for a unique case like this. How do we do the eye wall calculations? What targets? And is there anything with the higher order aberrations that can be helpful here? So I'll basically open it up to Dr. Dierker.
I'll jump in on this, and I think that this is going to be an interesting case. I can't wait to see the ending. In my practice, this patient, even before they get to a surgeon, needs to have their ocular surface tuned up. So someone that has hyperosmolarity, corneal staining, symptoms of dry eye, and I'm preparing the patient for cataract surgery, I think this patient certainly is going to need anti-inflammatory therapy, probably topical steroid, for several weeks, probably a topical immunomodulator. Once I get the inflammation under control, I'm going to look at those glands again and decide if we need to do some sort of obstruction removal. But I think if we can do that over the next month and repeat those calculations, and perhaps even before they get into your chair, I think an aggressive full court press on the ocular surface here is going to be in this patient's best interest.
Yeah, great thoughts. Anything different, Dr. Ayres?
Yeah, I totally agree, but you went through an awful lot of workup. It's just amazing how many people don't even remember what I had LASIK and what their prescription was before. I mean, they have no idea. And you can look and look and look on the surface, and it's amazing, especially with keratome LASIK, you can't see the flap after a couple of years in some cases. He did that really nice investigation looking for whether there was more positive or negative spherical or asphericity of the cornea, which is helpful at determining whether it was myopic or hyperopic LASIK. But there's so much surface disease here, it might mean nothing at this point. So I really think before we try and figure out, was this hyperopic or myopic LASIK, we've got to get the ocular surface under control. And I completely agree. In this case, I'm probably going to use, we want full court press and we want fast acting agents. So I'm going to add steroid here. I'm going to add topical immunomodulator, a lot of lubricating eye drops, plus or minus maybe something for obstruction of the meibomian glands. Anything to turbocharge this surface so we can get a better result, better biometry, better topography, so we can try and figure this puzzle out.
For sure. And, I certainly agree with all those points. If you're thinking about an IOL, would you consider a multifocal IOL in this case?
I don't even think we could have an IOL discussion at this point. The higher order aberrations, the topography, I think all of this is subject to change based on what the ocular surface looks like after we've done our full court press.
Yeah, I'll second that. I don't think that I can tell you what IOL I would use here, but I can tell you what IOL I'd like to use here, and that is a multifocal. We've used multifocals in post-refractive patients, both myopic and hyperopic, and I know that's a little bit taboo, but it's not the LASIK surgery that scares me, it's the ocular surface. So that's got to be under control first.
For sure. So basically, I'll kind of move the discussion along in terms of kind of what we did. This is the ocular surface tune-up protocol that I performed. This is my go-to protocol that I use in practice that works really well. We use thermal lid pulsation therapy. In this case, Systane Ilux is what we used. We did start her on aggressive topical corticosteroids. I like low potency corticosteroids, Flarex, FML, loteprednol, twice a day BID until the bottle is empty is how I have my patients use it. I put in short-term dissolvable prolong plugs. I don't want to use permanent plugs in active MGD. We institute aggressive lid hygiene with lid scrubs or Avenova, and I did use aggressive artificial tears. And with this regimen, we were able to normalize the ocular surface in about 3 or 4 weeks, and I didn't need to use topical immunomodulators for this case. So I'll kind of let the cat out of the bag in terms of what we ended up using was some new technology to do her case. We went ahead and decided that we would go ahead and do the surgery. We did her right eye first, again, her worst eye, and 1 week later we did her left eye. And we ended up using a light adjustable lens for her. The light adjustable lens is a great option for these post-refractive patients, and it really shines in post-RK patients as well in our hands. When you treat from the hyperopic direction with your light adjustments, you actually induce negative spherical aberration into the optical system, and so they get a depth of focus effect. So as you can see, we did 2 light delivery device adjustments, and we did 2 lock-in sessions to make her lens not sensitive to UV light. And she ended up with a 20/25 uncorrected outcome in her right eye, 20/20 in the left eye, 20/15 OU, and near J1. And what was nice, you can see the tear osmolarity scores are essentially normal now and have been maintained even after all the adjustments. So that really aggressive ocular surface tune-up in the front end pays dividends for this patient in the long run here.
And this is real similar to what we would offer in our practice. A post-refractive patient, we've had a light adjustable lens. We were part of the clinical trial years ago and then have introduced that again this year. And I think it's a wonderful case for that. This mini monovision works really well for these patients. But the one thing that will hang up and throw a wrench in the whole process of the surgery and the adjustments is untreated ocular surface disease.
Of course.
So I really think that you have to be aggressive, even more so with these light adjustable lenses, to make sure that this patient has the best experience and the best long-term outcome with this technology.
Yeah.
So, I second that. And I think as the cornea specialist in me, I would have done almost the exact same plans, same treatments, but I would have myself added a long-term anti-inflammatory because I see that rapid improvement with the steroid. I don't have an iLux device, but we have other devices that we use for treating MGD. They work great, they work fast, but they're limited run. So for me, in the long term, I'd probably also add a prescription anti-inflammatory thinking down the road so we don't get some regression of the OSD. But for pre-surgical planning, that's a great regimen.
Great, thank you. Well, thank you everybody for my case. It was an honor to present to you guys and my esteemed colleagues.
Thank you for tuning in to this first case of our three-part series, Case Studies in Treating Ocular Surface Disease. Stay tuned for part 2 of this series as Dr. Damon Dierker presents a case highlighting the benefits of proactive ocular surface management.